for being a part of the conference. All right. So moving on next, as we talk more about epigenetics, it's important that we dive deeper into methylation, how it can silence the suppressor genes, activate the oncogenes, and so many other things. And so for this we have Dr. Anish Musa. Well, he doesn't need an introduction. He is the driving force behind the Indian Association of Functional Medicine. He has been working very hard to create the FM ecosystem in India, be it providing training to budding practitioners or to really provide some high quality supplements in India, testing everything. Dr. Musa, you've been doing everything possible to build that ecosystem in functional medicine. So looking forward to hear from you about methylation and cancer.
Yes, Dr. Rui, thank you very much for introducing me. And it's not only me who is driving force behind IAFM, all of us, Dr. Rui, Dr. Preeti, and Dr. Ashwini, and rest of our community, we are spreading an awareness of functional medicine in India. And thank you very much, Dr. Shaili. She had given a background about the methylation. So now everybody learn that the methylation either is a hypermethylation that can suppress the preventive genetics, and then hypomethylation that can leads to non-activation of helping genes. So really the conclusion is we should be think about optimizing methylation. It's not on hyper. We should work on optimization of methylation. So my talk will be on methylation, how we can diagnose, and not only the methylation can affect your cancer, but I would like to just show you something over here and hope everybody can see my screen. So my question, so are you or your patient is suffering with any kind of cardiovascular disease? Because methylation is not going to only affect the cancer. Methylation is important for cardiovascular disease, atherosclerosis, and your patient is suffering with any kind of hormone dysfunction like hypothyroidism or estrogen dominance, because there is a connection within methylation and hormone balance. Your patient is suffering with autoimmunity or chronic inflammation. Do methylation play a role in inflammation? Your patient is suffering with any kind of neurodegenerative disorder like Parkinson's, Alzheimer, or depression. Is there connection within methylation and your brain function? Is your patient is suffering with any kind of metabolic disorder or fibromyalgia or fatigue? So I just want to tell you that something is going on in all the disease and central process. So let me just give you idea about what is functional medicine that can help you. So Dr. Shaili told it's a genetic. Yes, of course, genes are playing a role, right? So genes and epigenetics, they play a role. But here in functional medicine, we know the environment can turn on the genes and environment change can turn off the genes. And one of the major mechanisms that we learn is methylation. But as if you have a right kind of environment, then your genes react with the right kind of environment, and then you have a normal functions. Your normal functions of your immune system, your nervous system, your digestive functions, your metabolic function. But just think about if your bad lifestyle choices and your environment that you are living, your toxic thought, you are exposed to chemicals, you are exposed to food toxins, you are exposed to sugar. So if your diet, lifestyle, nutrition, and that's we call environment, including your emotions. So that environment, if they're healthy and supportive to your genes, then you can reach your health and wellness. But at the same time, if your environment is not supportive to your genes, you end up with a chronic illness and chronic health conditions, right? So it's very important to understand, and we will not talk about genetics that we cannot modify. So here we talk about the environment that we can modify. Why should we always worried about the genes we are carrying that have a risk of developing any kind of disease? We should at least focus something we can do, and that's the epigenetics, that's the environmental change we can do. And whole my talk is on how we can optimize this part. So one of the common cellular process, and that is methylation. Now I want you to aware about what is the methylation process and how it's going to affect each and every cell in your body, because from methylation is actually CS3. So if you If you know the biochemistry, then it's actually C carbon with an 3 hydrogen, and that's CH3 group. So why it is important for each and every cell? Because for every biochemical process in the cell, we need to shuffle this CH3 group, or we can say methyl group. And that methyl group can help in detoxification phase 2 process. Like if you want to metabolize your estrogen, yes, of course you need methylation, because methylation can detoxify your estrogen properly and other chemicals. So methylation is also a part of detoxification process, and that's a phase 2 detox that your liver are doing on every single day, that you need this methyl group for the process. As I mentioned, your hormone production. So if you look at the hormone production from your thyroid, from your ovary, and all the chemical process, gene expression required, so that hormone production detoxification required methyl donor and methylation over there. And then you can see neurotransmitter. So we talk about the happy hormones, dopamine, serotonin, how they manufacture, what the chemical process is going on in the cell to manufacture this neuroendocrine system. So they require the methylation. And as we have a whole lecture, Dr. Shaili has told about the DNA methylation and gene expression. So if you have hypermethylation, that's a problem. If you have hypomethylation, then problem right now we are facing is hypomethylation, and that hypomethylation will have a genetic expression of wrong kind of genes, and that leads to the expression of cancer and other disease. Energy metabolism. So look at energy metabolism. We require to shuffle, and all the energy metabolism we require to have a proper methyl group over there. And then our immune system need methylation and methyl donor, and cellular membranes and their signaling and mechanism, all they need methyl group and methylation. So that's very important cellular process of methylation. If your methylation is optimal, so I will say you, not high and hypo, I will say you, if we want to be healthy, if we want to age healthy, that means we want to have a proper methylation in each and every cells of ours. And that's what I want to show you something over here. And I don't want to scare within biochemistry pathway. And you can see a lot of interaction, which I just want you to show you that's important of methylation. And there are so many genes they are playing a role in methylation, not just an MTHFR. There are many genes who play a role for methylation. And look at the biochemistry. You can just look at the one methyl group that is shuffling from one end to other end, and so many processes are going on. But I will not going to teach you this one, but I want to make you simplify the methylation process within some simple cycle that everybody know about the MTHFR genes. So let's look at the simplified version of methyl biochemistry. I want you to just focus on a 2 amino acids. Even you can see a 1 amino acid, that is methionine on the top of that. So methionine is an amino acid, and then methionine is actually a methyl donor. So if you look at the protein, which protein can supply you a methyl donor? That's the methionine that can supply you a methyl donor. But methionine and then homocysteine you can see in a center part, and then homocysteine can be converted to methionine, but that conversion required MTHFR genes. And there are cofactor you can see, they are the folate and the B12. I just want to highlight that. And this, if you understand this biochemistry in a simple way, our $1,000,000 question is how we can diagnose methylation defect, or how we can diagnose whether my body or my cell have a hypermethylation or a hypomethylation. And that's why this slide has to be understood very clearly. So just focus on a homocysteine, and if your homocysteine is optimized, it means your methylation is optimized in some sense, we can say, and that required proper activation of your MTHFR genes, and then they require a cofactor, and this cofactor is your folate and B12. Now, I just want to make you aware about vitamins, because you find out that folic acid is vitamin B9, but if you look and deeper in science, then folic acid is not vitamin B9. Folic acid is synthetic version of vitamin B9, That means the active vitamin B9 is 5-tetrahydromethylfolate, and precisely it's the 6S 5-tetrahydromethylfolate that is discovered as a vitamin B9 in biochemistry, and then folic acid is a synthetic version of that B9. So that means acid, then folic acid has to pass through all the processes and then it has to convert into active vitamin B9. And that required one enzyme, and that enzyme is called methyl tetrahydrofolate reductase. And that is controlled by the gene that we call MTHFR. So if you have a good expression of MTHFR, you're going to make the enzyme. And if you can make the enzyme, then and then you can convert your folic acid to your active folate, that is 5-tetrahydromethylfolate. But if you don't have an expression or if you have any kind of genetic variation, and that leads to the MTHFR variation, or we can say MTHFR defect. And if you have MTHFR defect, you are a poor converter of folic acid to active forms of B9. And that cofactor required B6, B12, and folate. So that means that we have to deep dive also in the genetics, and also we have to work on epigenetics, and that's a methyl donor supplier. So let's say how we can diagnose methylation defect. Like we have clearly understood that the optimal methylation should be there, but if the optimal methylation is diagnosed by a simple blood test, although you can do a genetic testing, we talk about that also, but the simple testing I do with all my patients is check their homocysteine level. So homocysteine level, and you can look at the cardiovascular disease, and that says hyperhomocysteine is responsible for cardiovascular disease. Even hyperhomocysteine can lead to responsible for some kind, and there is some correlation with cancer over there. But let's say I do a simple testing with all my patients, and I want to find out whether that methylation is optimal, or even they have any kind of genetic variation or methylation defect. I do the blood test homocysteine. Now here we have to understand clearly that we need optimal methylation. And if you look at all the reference range in the conventional lab, they says that 14.5 is a cutoff point for the homocysteine. But as we are not just looking at the cutoff point, we look to optimize the homocysteine level, and optimize homocysteine level is less than 7, 5 to 7. So if you are less than 5, we can say hypermethylation. If your level is more than 7 or 8, we can say it's a hypomethylation. So really homocysteine will tell us that our cell is optimized for methylation, because we know that central cellular process that is happening in the cell that will shuffle your methyl group from homocysteine to a methionine, and there is an indirect clue of methylation defect. So important thing is, if we want to optimize the methylation, then we need methyl donor, and then methyl donor should come from the food, and CS3 group, that's a methyl donor, and we should eat that kind of food. They gives us methyl donor, and one of the two methyl donor that usually patients are low, they are your B12 and folate. Now, if you look at the proper name of proper or active names of B12, it's a methylcobalamin. Name itself shows us it's a methylcobalamin. It's a methyl donor. Now, if you look at the folic acid is synthetic version. Now, what is the active forms of folic acid? We know there is a methyl folate. So you can find out the methyl donor. So if you want to optimize the if you want to diagnose the methylation, then we have to look at the supply of methyl donor by looking at the methionine, by looking at the other methyl supplier, or we can just simply look at the B12 level and the folate level, and you can have an idea about the methyl donor from your food. And usually you see most patients, if they have cancer or any chronic condition, they actually have a low methyl donor. And because they have a low methyl donor, the methylation is not proper. You can see the homocysteine level increased. In some patients, you can see above optimal, or in many patients, when there was severe defect, you can see higher. So in this case, you can see the patient having a lack of methyl donor from the food, and that's why their methylation is not optimal, and homocysteine level is raised little bit on optimal, above optimal side. But let's look at another case where you can see very high level of homocysteine. It is more than 29. Even it is more than a standard range. Like homocysteine level is 29, that is too high. And then you look at the methyl donors. Now look at the methyl donor from the food that you should eat. You should having an B12 and folate from your food. But when you check your B12 and folate, you can see B12 and folic acid, they are nearly in optimal range, the good range. Then the question is, if there was sufficient methyl donor or there was sufficient amount of B12 and folate, why the homocysteine level is raised? And then you suspect that, oh, my patient has some kind of genetic variation or they have a mutation in their MTHFR genes, and that's why they have a hyperhomocysteine. Now, this genetic variation could be like homozygous or heterozygous. Now, there are two commonly genes involved in the MTHFR, and that genes can be a heterozygous or homozygous. Homozygous means only both the genes are involved, and that gives you a minor defect in your MTHFR genes. While if you have both the genes are involved, because we are carrying a one set from a mother and other set we are carrying from the father. So if both the genes are involved, that we can say homozygous involvement of both the defective genes, and then that's create a severe defect. I had seen some patient with multiple chronic conditions, like they have a thyroid, they have a diabetes, they have some kind of depression or gut issues. And when I check their homocysteine level, it is usually more than 30 or 35. And then I usually suspect that this patient having an homozygous or both the genes are involved for MTHFR defect, and that's make them severe. So important thing is, as we know, the genetic expression could be leads to the chronic condition, but our question is how we can optimize the methylation. So we had learned till now that methylation is very important, and methylation is cellular process that is affecting each and every cell. And then there is a genes involved for the methylation. We had only learned the one gene, that is MTHFR. But apart from MTHFR, there are many genes who play a role in methylation. And then we had learned that methylation defect can be diagnosed just by looking at the homocysteine level and the level of methyl donor. Now, if we are aligned with an understanding of methylation is important and methylation defect we have to cover, then the $1,000,000 question is how we can optimize methylation. And if you can optimize the one factor, that is a methylation, you are not only preventing your chronic condition, you are not only preventing your cancer, but you're also working on anti-aging. So then that's very important, because aging is also expression of your genetics, and then you can optimize the expression of your genetics, and then you can move your expression to unhealthy sides, including your other lifestyle. But that's very important that we have to optimize the methylation. Let me give you idea about how you can optimize the methylation, and let's look at the simple slide. But this is a complex slide. I would like to make you simplified for you. Now you can see there are many factors involved in the methylation, and when we want to optimize the methylation, we have to optimize our lifestyle, we have to optimize our diet, and we have to optimize our nutrition, right? So let's talk about dietary changes that we can do and that can increase methyl donor in a diet. So important message is, we as a population, we are having an low methylation, and because we have a lack of methyl donor in the food. And the two things you have learned from me is B12 and folate, and there are other methyl donor that we can say, like methionine is amino acid, so you can get good amount of protein in your diet. So protein is required because protein also contain a methyl donor, so your protein should be focused. And now look at the data in a Indian population. So we are having a deficiency, widespread deficiency of protein in our diet. 80 to 90% of Indian population, they have a deficiency of dietary protein. So if you have deficiency of dietary protein, how you can get the methyl donor? And look at all the patients they are entering in your clinic and just check in one marker B12. It is always low. And then you check a second marker of folic acid or other biomarkers, then you find out that my patient having a deficiency of methyl donor in their food. And if you have a deficiency of methyl donor, how you can optimize your methylation pathway? So one important message is we have to take an protein, and that should contain a good methyl donor. So optimize your protein, right? And then you have to optimize your B complex, like B12 and folate that you optimize. Just look at the food source of B12 and folate. As a vegetarian in Indian population, we are deficient in B12. Just there are various ways you can optimize your B12 and a folate. Then you should know about your genetics. Like if you have any kind of genetic variation, then you should optimize and your requirement of B12, folate, and methyl donor is higher. One important thing is not everybody we treat in our clinic are same. It depend upon your genetics and your genetic expression. So if your MTHFR genetic variation, your requirement of B12 and folate is higher. If your severe genetic variation in MTHFR, like I said, you homozygous, then you cannot take a folic acid. Just learn the important message. If your severe homocysteine level is high, you cannot take a folic acid because folic acid cannot convert to the active form. And then your cell will always have a competition with inactive forms and active forms. Folic acid will not directly go and change your gene expression. It's a methyl folate that work in your body. And that folic acid has to go in all four pathways, and then finally it required MTHFR genes to convert that into a active forms. So folic acid doesn't have a CH3 group, and we are talking about the methyl group. So folic acid is a lack of methyl group. When you want to even convert the folic acid, you require methyl donor. And usually that methyl donor is coming from your B12, and that's how your folic acid is converting into active forms. So important message is that if you have genetic variation, you can do, and now this testing is available in most lab, you can do it. And by the way, somebody asked about what is the percentage of population they have an MTHFR defect. So as per my studies, we had find out 20 to 30% of global population, they have some genetic variation in their MTHFR genes. Either they are homozygous or heterozygous. And as I mentioned you, that is not only the MTHFR, there are other genes that are involved in methylation cycle. But methylation cycle is impaired in almost 30 to 40% of population in India and globally. One of the reasons is we have a lack of methyl donor in our diet. And then you can see if you want to optimize the methylation, we need a protein, and look at your gut function. Are you absorbing that protein, or are your patient is on a proton pump inhibitor, or they are in a drug? Or what is the absorption of B12 they are taking? Let's say your patient is diabetic and a patient is taking a metformin. So we know that metformin is preventing the absorption of B12. So that's going to affect your patient's B12 level, and then you have to supplement the sublingual B12, or maybe you can think about the IV or IM B12. So these are the factors you can optimize in some way. We require magnesium for working in methylation because our cell work in synergy. All the nutrition, all the minerals, they require for proper working and proper biochemical reactions. And that's why we need the optimal level of other nutrition within B12 and folate and other methyl donor. Look at vitamin B, vitamin D. Vitamin D is also important for your gut and your immune system. That's required a B12. So here you can optimize your diet, and the proper thing is you increase nutrition dense diet, not just looking at the calorie. Don't count your calorie. Calorie is important, but here we are talking about the optimization of a cellular function. That means you need to work on this kind of factor. Then if you have a methylation defect, then go with an active nutrition supplement, so support with a nutrition. You can take an active forms of B12 or active forms of B6 and B12 that you should know. And you should know the difference between the cyanocobalamin and methylcobalamin. You should know the difference between the folic acid and your methylfolate, and what are the different kind of active nutrition available. So just want to make you aware about that part. And then finally you work on your lifestyle, and that way you can optimize your methylation pathway. And if you check your homocysteine, or if you check your genetics, you can better take an informed decision how much B12 or folate you require. But that's a very important cycle. You can learn these things. As in IAFM, we are mission to provide the knowledge. We are the mission to provide you a functional medicine knowledge that you can transform the lives, and you can give a promoting long lasting wellness and health to your patients. As you know, what I shown you is a one piece of puzzle, and that's the methylation. Apart from this puzzle, we can show you, and we can teach you how you can optimize your gut function, how you can optimize your immune system, and that way you can learn and add up the functional medicine model. I can see that many conventional doctors, they are interested in the functional medicine. 4 years back, we are a few doctors who are starting promoting functional medicine, and this is our 4th year where we are spreading awareness of functional medicine. But I want you to take a participation and go further and add up this functional medicine model, and then functional medicine model can connect all the dots. We are not against any kind of conventional medicine or Ayurvedic medicine or other medicine, but finally look at this: they are medicine. If you have any disease, that doesn't mean that you are deficient in that disease. For example, if you have a diabetes, that doesn't mean you are deficient in metformin. Or if you are Ayurvedic doctor and if you are giving some herbs, that doesn't mean the patient is deficient in that herbs. Herbs is important, but we as a clinician or doctor, we are missing a primary three component of a healing. That's your diet, that's your nutrition, and that's your lifestyle, and that could be a foundation. Then we can think about what medicine we require to heal that patients. So you can learn the functional medicine principle. You can find out the tools that you require to add up this new learning and new way of thinking. If we want to transit our thinking, and we have to think out of box, and we need a different map to understand this clinical model. We need to find out how my patient developed the disease, what is the root cause, and then you learn all cellular process. So if you look at the functional medicine model, it's based on physiology, functions of the body. We look at the immune function, we look at the methylation function, we look at the gut function, we look at your detoxification functions, we look at your hormone functions, and that is continuous education and practical implications of functional medicine, that you can add up the system, and you can go forward and combine your practice with a conventional medicine mind or Ayurvedic mind or any nutritional professional. They want to add up the functional medicine model, because we work on a basic foundational medicine. Then you can add up. And this is, you can learn more functional medicine by looking at this link, or you can contact our IAFM team. We have a various program in IAFM also. So if you are keenly interested in learning functional medicine, I would like to invite you to contact IAFM. We have different programs for everybody, and you can learn this model, and you can go forward to train and treat your patients. And that's we call a future of medicine. You believe or not, this going to come, and then we have to add up the system if we want to change and if we want to progress. As Einstein said, that if we want to progress or we want to evolve, we need a different kind of thinking. And right now, in a conventional world, we can see a rise of disease and chronic conditions, and all these things are there. And as a conventional thinking, we are failed to answer that questions. And then we require a new thinking, different kind of mindset, and we have to open our heart and ego, and we have to think beyond. And finally, only we have to answer the question how I can help my patients, and that's make a functional medicine model to work. And that's it, Dr. Hui. Thank you very much for giving me opportunity to speak along with you. And
Thank you so much, Dr. Musa. You have beautifully made the complex topic of methylation so simple and easy to understand. There are a lot of questions in the chat. We'll take one question and maybe you can stay back to answer a few. So, high methionine is equivalent to high homocysteine, or it's the opposite?
no, see, methionine is amino acid, and methionine usually you get from the food, and your body can convert homocysteine to methionine. So if you want to just look at the one biomarker, that's a homocysteine. So high homocysteine means poor methylation. Optimal homocysteine means your optimal methylation. Low homocysteine means your hypermethylation. So that way, the one indicator you can look, and you can just look at your cell, and you can find out the methylation process. The range you have to understand. The range will be 5 to 7.2 or 7.5. That is the optimal range for homocysteine. Above that or below that, we consider them as a optimally high and optimally low. So make sure you look at the correct number and don't just go within a current standard lab. Otherwise, you will be not properly diagnosing methylation.
Yes. Yeah. Thank you so much.